Welcome. Welcome, everybody. Welcome to Vienna. Welcome to this edition of the Europerio. My name is Andreas Utz. I'm heading the global implant business for the Straumann Group, and it's my pleasure to welcome all of you today in Vienna to this edition of the Straumann Corporate Forum, and welcome also Franz. Thanks for being our moderator today.
It is actually a great pleasure, my dear colleagues, my dear friends, to host this very interesting session. I mean, immediacy and, of course, periodontology and peri-implant health is definitely some topics that are very close to my heart. So this is a great honor.
Franz, I think based on your clinical knowledge and deep expertise in immediacy and your deep training and specialization in periodontology, there's no one better that could actually moderate and run this session. But I have a question for you. You know, linking immediacy to long-term soft tissue stability doesn't seem like a natural combination and intuitive link. Where is the link of those topics?
You know, Andreas, for me the connection is obvious. I mean, it's not because we do immediacy, it's not because we want to be faster with our treatment that we should not consider peri-implant health. So, I mean, it doesn't matter the workflow, doesn't matter which protocol you're going to use. I mean, putting the priority on peri-implant health and long-term function and health of our implant should be applied to any type of protocol.
Okay. As a clinician, how often do you experience this topic? I mean, on a scale from 1 to 10, how present is this topic of peri-implantitis in your practice?
You know, I think this should be there every day, you know, on the daily practice. Of course, we're doing great things with implant. We're restoring smile and mouth, but this should be something reliable. So definitely, this is the daily routine for us. Dentists, periodontists, dental hygienists, and so on. But, you know, I'm very curious to understand what is your point of view, actually, as an industry. I mean, where do you put this in your priority? What is your vision, your long-term vision about that?
Yeah, I mean, as the leader in implantology, you know, we have to take this topic very serious. You know, there are people that try to avoid speaking about this topic. We take it very serious because it's there. Implant dentistry is an amazingly successful treatment option for patients. It's very safe if you do it right, but we have to admit this is a big topic, peri-implantitis. So we take this very serious. It's a topic in our innovation themes. It's a topic in research. We have long-term research projects, so we try to also look into how we can solve this with new products that we bring to market. But it has to be also a fact and a reality in every single product that we develop and bring to market, because there's also a preventive element to peri-implantitis. The design of products and implants in specific has a huge impact on peri-implant soft tissue stability, as we know from the tissue level implants, and we have strong data on this. So also putting data behind this evidence is very important, and ultimately, for us, I believe this is the challenge that we really have to solve together. Us as industry, we put, you know, focus in innovation and research, but we need you as clinicians and researchers and scientists as well to help us.
It is actually very nice that we are working on common grounds with common objectives. But I think the industry and the clinician and the researcher community is very complementary. And I really hope that with this session today, we can really demonstrate how we can combine immediacy and peri-implant health, and how we can actually also integrate the overall dental team, and including also other discipline or other tools, such as orthodontics, in the restoration of a smile of a patient. So,
with this, I wish all of you an exciting session. Thanks, Jasper, for joining us as a speaker. Thanks, Miha, for joining us as a speaker. And Frank, thanks also for being here. Franz, the stage is yours. Thanks a lot.
Thank you so much, Andreas. So we were basically talking about patients. You know, what do they want? What makes patients satisfied and happy? Well, I think one of the first things, actually, is that people do not want to have pain. And they don't like to have surgeries with you guys. So the other thing is, I'm not sure they like to come to your practice or a million times to your practice. So definitely time is precious now, and I think patient would like to spend more time outside the practice than inside the practice. Of course, they want results. They want aesthetic, functional, and health over the long run. But they also would like all this for something that is cost-effective, as cheap as possible. So this is a difficult equation. And if we look at conventional workflows, conventional approach for implant placement, delayed implant placement, these protocols, they take actually quite a lot of time, you know, whether this is anterior or posterior. This is quite invasive because there are multiple surgeries, you know, from extraction, regeneration, implant placement, loading, and so on. And this takes like several visits, minimum 5, sometimes way more. And of course, the more visits, usually the more cost for the practice, of course, but also for the patient. So now, what if we propose our patient like a protocol like this, where he comes with failing teeth, and in 1 hour, it's going from here to here. Of course, this is very attractive. And of course, this is what we are doing more and more. But we need to be able to make this reliable on the long run. We need to have, after 10, 15, 20 years, aesthetic and function, but also peri-implant health. There are more and more evidence regarding immediate implant. And I'm sure my colleagues will highlight that in more details. But now we can consider that an immediate implant, especially in the aesthetic zone, is a reliable protocol, especially in favorable conditions. But this type of disease, peri-implant disease, is still there. And we want to prevent that. We want to keep this as much away from our daily practice. And I'd like here to introduce the S3 level guideline that the EFP worked on the prevention and the management of peri-implant disease. And you see that the prevention of peri-implant disease is basically divided in different phases, with the primordial prevention, that is everything you do actually before or during the time of implant placement. And then you have the primary prevention in order to avoid the development of the disease. And even if you have the disease, you need, of course, to treat and to take care of the disease and then go for a secondary and sometimes a tertiary prevention. We are going in this session focus on everything that is primordial, everything you can do before and at the time of implant placement. We are in a perio congress, and of course one of the key things is that you place your implant only once the periodontal disease is stable and treated. And then, once you consider the implant placement, you go for the primordial prevention, which is the prevention or the reduction of local risk factor. And basically, the key strategies will be, and this is in the guideline, the 3-dimensional implant positioning, the hard and soft tissue management, and working also with a cleanable prosthetic design, and if possible, avoid cement restorations. And with this, I'd like to highlight a few of the topics we are going to discuss in the next hour or hour and a half with this patient. You know, this is this patient that has failing anterior central incisor. And when we do the aesthetic analysis, we can see that actually we can look a little bit beyond the 2 central. And in this case, you know, the occlusal plane is not straight. And definitely in a case like that, we would want to propose orthodontics to this patient. So basically, we are going to look in this session on how orthodontics can enhance the overall treatment, because we're not treating a tooth, we're treating a patient. And then once the orthodontic is completed, then we can think of the implant placement. And there, based on imaging and clinical evaluation, we need to have the proper case selection, and indications for immediate implant will be addressed in this session. We will also address the importance of the planning, the actually prosthodontically driven planning, to finally address the surgery that comes in general with immediate implant with an extraction, but we also need to understand the post-extractional biology. This is another key topic we will discuss. Of course, the surgical aspects of immediate implant with the hard and soft tissue management. And finally, we were talking about planning that are prosthetically driven. But the prosthetic approach is also super important for the final result, not only the immediate result, but also the long-term result. So we will address the transmucosal design, the immediate loading procedures, because immediacy often goes, you know, we have immediate implant, immediate loading. This can be together or maybe addressed separately. So there are indications for immediate loading or not. And then we will also address materials and design for the final prosthetic, because we've seen that this is very decisive as well for the long-term health of our implants. And basically, at the end, we want to look at what are the long-term outcomes, what are the evidence, and at the end, what we want to also provide is a primary prevention to the implant we place, addressing avoiding the development of the disease with basically providing a proper home care guidelines to your patient, home care techniques, and of course, propose your patient a specific program for supportive peri-implant care, which is definitely one of the key aspects to maintain peri-implant health. So basically, all this together, we hope that we can provide proper treatment to our patients to make them happy and satisfied. So with this, I'd like to invite the first speaker on stage, so Professor Frank Schwarz. He is our first speaker, and Frank will address the case selection, the decision-making for immediate implant, the surgical approach, immediate loading. Professor Frank Schwarz is the head of the oral surgery department at the University of Frankfurt. I mean, I'm not even sure I have to detail his CV. This is super long. He is a landmark in the field. So, Frank, the stage is yours.
Thank you so much. Thank you so much, France. So, dear colleagues and friends, it's really great seeing so many of you here attending or joining this meeting. So, really fantastic. Thank you so much. So, Straumann, you did a great job as always. So, a big thank you also from my side. And I would like to take 25 minutes of your time to guide you a little bit through our daily work in Frankfurt, because in this clinic that I joined now almost 9 years ago, we have, of course, a strong focus also on immediacy. And this happened right before my time. And from the team, we have a core group that has a focus on implant therapy. And Puria Pavini is one of these collaborators that early on focused on immediacy. And honestly, when I joined the department, I was more on the track of type 3, type 4 implant placements, but I definitely converted. I was really convinced by all these advantages that we will be discussing. Always keep in mind peri-implant diseases. So together with Austria, we always focus on peri-implant health and the management of peri-implantitis. That's why this is always the utmost relevant point, that we do not run into complications by using these protocols. So, France, that was a landmark consensus because it again underlined the evidence that we have. So this is really striking. There is a lot of evidence for immediacy protocols, and of course you all know it. But again, let make me this point very simple and clear. We extract the tooth, we place the implant at the same day. So this is what we define as immediate implant placement. And in our workflow, in our protocol, we routinely focus on immediate restoration. So this is again important to underline, out of occlusion and the delivery of the prosthesis within 1 week. Of course, as for any other treatment protocol that we use, we have some site-specific aspects, so case selection criteria. And I would like to highlight my 4 most relevant risk factors that we take into careful consideration. So periodontal disease, the thickness of the facial bone wall, the overall bone quantity and quality, and the soft tissue quality, and I will go into each and every detail. So let me first start with the population that we have in our clinic for immediacy. And when we look at the distribution for tooth extraction reasons, it becomes apparent that most of them that we select for immediacy protocols are due to fractures. Endodontically treated teeth, 30%. So these are the main, by far, the main target group. The implant location, as you can see, premolar sites are dominant. Of course, more anterior teeth as well, but the vast majority are in the premolar region. And in the upper jaw, of course, we have always a little bit the dilemma that the bone quality is not that high. That means we are always within a type 3 and 4 bone quality. So these are a little bit the characteristics of our patients that we treat in the clinic. So not a trivial question is tooth extraction, right? So sometimes when you have a fractured tooth, it's not that simple to just pull it out for many reasons that we all know. And immediacy is, in its strictest sense, of course, mainly a flapless approach. So in order to remove a tooth without major complications, and the complication would be you have to raise a flap. In the worst case, you have to start with an osteotomy to get out the root. So this is, of course, contra-directional to the overall concept. So we want to preserve the buccal bone, and that's why we take advantage of an extraction tool that we routinely use. And I would really recommend you to at least have a look at such an extraction tool. So this is the extraction screw. So we drill a hole. Let's say within the root canal, we apply this extraction screw. And with this device, which is covered by Teflon in order to prevent damages to the adjacent teeth and structures, we can easily pull out the tooth or the root in an axial direction. That means we do not at all compromise the buccal bone. So is the buccal bone intact or not? So this is, of course, one of the main decision-making factors. And you can, of course, evaluate it in advance with the CBCT, but you can also simply check it by means of a periodontal probe. So now we know, is the buccal bone intact or is it non-intact? So coming back to this first risk factor, which is periodontal disease, apart, of course, from the overall effect of bacteria in the mouth, we have to consider the local effects of periodontitis, endodontic lesions, on, of course, the structure of the socket. And this becomes apparent on the left-hand side. You see this periapical translucency, and you see the massive impact of the infection on the buccal bone, which, of course, makes this case by far more complicated than an intact socket. And this is what you have to understand, what you have to keep in mind. History of periodontitis, periodontal infections, but also endodontic lesions and combinations thereof. They usually compromise severely the buccal bone, and these sites are by far more critical. So keeping that in mind, we have, of course, the most ideal scenario likely in case of a fractured root or a fractured tooth. So the treatment protocols and the procedures, and of course there are many, many different perspectives that we could discuss, but again, I would like to focus on our approach in Frankfurt. So this is a quite interesting case. You see here on the left-hand side, at least from your perspective, so the third quadrant. This is the extraction of the canine and the first premolar. On the opposite side, I had extracted exactly the same teeth 4 months ago. And as you can see, we get, as a result of tooth extraction, a massive collapse and a remodeling of the bone, and that's why there is a clear difference in terms of preservation of tissues or loss of tissue structures during the healing phase, and that's why in many cases you have to apply additional bone grafting procedures to make the site appropriate for an implant placement. So this is definitely one advantage of the immediacy protocol, so you have a better volume of the tissues right at the time of surgery. So a little bit looking back at the history of implant designs, because they make a huge difference when it comes to immediacy protocols. It's the old Straumann TE implant. And Andreas, I think it's still available, right? You can still get it. Yeah, of course. But this is, of course, not the design that we use today, because at these times it was, of course, a different understanding of the biology of extraction socket healing. Now we, of course, go in different designs. So in our clinic, we have the BLT. We have now switched to the BLC, so a modification of the BLT implant. The BLX with the progressive threaded design, and of course, for the prevention of peri-implant diseases, we know it from the literature, one-piece implants, they always have an advantage with regard to cleansibility, and this is the TLX. So this is our armamentarium for immediacy, and in most of the cases, we of course use progressively threaded implant designs, and with the torque fit connection that also applies to the BLC implant, you would just need one surgical kit and you could use all the 3 implant systems out of the box. So that is a big advantage for our daily work. So a little bit to better understand the selection of an implant design. So when we look at this extraction site, or this tooth that is going to be extracted, we see we have an anatomical situation with the foramen mentale very close to the apex. That means when we extract the tooth, when we place an implant without having a progressive thread design, we would need to get the anchorage beyond the apex of the socket. That means we have to go a little bit closer to this anatomical risk structure, and this is of course a surgical risk. So that means we need longer implants, and with the progressive thread design we can go the other way. We get the anchorage in the adjacent bone. That means we can stay within the confines of the extraction socket, and this gives us much more flexibility and of course safety in order to prevent damages to adjacent anatomical structures. So this is just one example. So some people still have concerns to malposition the implant in the extraction socket, and for good reasons, because it's not that simple. It's not that simple. But whatever you use, whatever type of protocol you use, you always have to consider this safety zone. And the safety zone is, as you all know, the emergence point from the adjacent teeth, the connection. This line should, of course, be always kept inside, at least 1.5 to 2 millimeter distance to this line. And even if you are experienced, you can use a ligature to just make it visible when you place the implant. So this is really helpful. Another point is, as you all know, the position of the tooth is always misleading, especially in the upper jaw, in the aesthetic zone, because the implant position would definitely be within this danger zone. So the implant will definitely go in the wrong position. And that's why we need to go out of this position of the tooth, and ideally you make the entry point in the bone in the upper third of the extraction socket to the palatal side. So this is the entry point, and you go out of the extraction socket. So this is in principle, and sometimes when you are not that experienced, indeed, the first critical step into this protocol. So that's why I would highly encourage all of you who are not that familiar with immediate implant placement to of course, use guided surgery. So this makes the entire procedure much more appropriate and easier. So here we have checked with the probe, the buccal bone is intact. We have our 3D planning in advance. We have now the guide. The guide is fitting well. And now comes the easy part. We just place, or we just use the subsequent burrs here for the BLX implant. So we start with 2.2, now 2.8. The positioning is, as we have discussed, we are within this confined area where we can definitely define or expect the best aesthetic outcomes and the placement of the implant. So this is, from that point on, really straightforward and quite simple, as long as you have the proper case and you have, of course, considered a proper planning. So what you see here is the insertion torque. And the insertion torque is a crucial component, especially when you think about immediate restoration protocols. So for the BLX implant, this is always an easy task. So we can easily get 50, 60 Newton centimeters. So this is quite simple with this progressive threaded implant design. But we define, and not just we, it's the literature who points to a range of at least 35 to 45 Newton centimeter to consider this implant appropriate for immediate restoration. So here we have achieved 50, it's perfectly fine. So the next question, for some people this is a little bit a philosophical question. So should we craft the gap or should we leave it just with the blood cloth? So of course in science we should not talk about what we think, we should talk about what we know. And what we know is quite simple. We know that when we fill the gap, we have just advantages. And the advantages are mainly measured by means of aesthetic outcomes, so we can better preserve the mucosal margin, the mid-facial, especially the mid-facial aspect. So we have good reasons to fill the gap. And this is what we always do. So again, in the case where we have a sufficient primary stability in the aesthetic zone, so why shouldn't we proceed with the next step? And the next step is here the scan body. The lab technician in Frankfurt at the university, we have many lab technicians, so they, of course, support us. They come in the surgery, they come to us, they do the scan, and they start immediately while we are still suturing or making the final steps of the surgery. They are preparing the final abutment, because this is based on the so-called one abutment, one time principle, ideally. And they prepare some other components. So again, what we get from the lab technician within about 2.5 to 3 hours is the following. So we get the final abutment, so titanium base and a mesostructure. We get the final, let's say, the core of the final crown, and we get the provisional crown. So with that, we start. We go back about 2.5 hours later. We connect the final abutment with the final torque, and we will not touch the abutment again. So we will just bring it to the 35 Newton centimeter. That's why it's always better being a little bit higher with the insertion torque than with the final torque for the abutment screw. So this is the final abutment. This is the core of the final crown. So now we make sure that we register the position of the abutment and, of course, of the implant, because this will be used for the final crown, which will be delivered usually after 4 to 6 months. So here with the chick, very simple, takes 2 minutes. We have registered the position, and now we do the extraoral pre-cementation here with the replica of the abutment in order to avoid excess of cement. So think about cement as a risk factor for peri-implantitis. So this is what we can easily avoid. And we deliver the provisional crown here without occlusion, without contact, so it's just for the purpose of providing an aesthetic outcome. So this is just the sequencing. A quite simple, straightforward approach. So even if you are not having a lab technician in your office, you can deliver at least in the evening or a day after the final provisional restoration. So just in case that you don't get the desired primary stability, let's say you have 25 or 50 Newton centimeter, the implant is still in a proper and a good stable position. We craft the gap and we use a punch to close the site and to keep it for the next couple of months under a closed healing condition without raising a flap, because that will, of course, be detrimental to the soft tissues. So, putting these components together, and these are one of the major components that we have to discuss, so crafting and loading. We look at an experimental study here with the TLX implant, where we have placed the implants in extraction sites, we crafted, and here in the mini pic, this is really loading. So this is not a provisional restoration, this is really loading. And as you can see, in the 4 groups, the group that had received both loading and crafting, we obtained the best outcomes. So the best marginal bone levels, assessed histologically, and the highest mucosal margin. That means we have soft and hard tissue components that are clearly supported by combining these two factors. So from that perspective, we should just briefly look at the evidence that we have for the immediacy protocol. So Jan Kosein, he is doing excellent work with his team and providing excellent systematic reviews. So this is a comparison between type 1 and the early placement type 2. And as you can see, we have similar clinical outcomes in terms of survival and mainly aesthetic outcomes. So for the comparison type 1 versus type 3, we have, again, similar outcomes in terms of long-term stability, but slightly higher implant losses, early implant losses, and this is likely due to the fact that studies that were included in the systematic review did, of course, also employ older implant designs without having a progressive thread design. So this is, of course, a critical component, using the proper implant design. So looking at the case, here I have extracted the 4 central and lateral incisors here in the patient, and we went into the protocol that we have just discussed. So I had placed 1 BLX implant in the extraction socket region 3-2, and on the other hand side, I was out of the extraction socket, I was in the native bone. So I could avoid to go into the extraction socket. So the implant was immediately scanned, the position was scanned, we did, here in this case, a rich preservation of the extraction sockets, the membrane, and we go for the transmucosal healing. And the same day, in the afternoon, we delivered this provisional restoration. So in the lower jaw, it's always more difficult to be out of occlusion, out of contact, and you heavily rely on the behavior of the patient. But also with regard to the oral hygiene, and this patient was really the worst cleaner I have ever seen. And I didn't realize it beforehand, I just saw it. It seems to be that she stopped to clean once she had received the implant. So that was strange enough. But as you can see, that was the result. There was an infection, and the implant in the region 3-3 did not integrate, so we got an implant failure early on. So this is something that can happen, but this can happen with any type of course, treatment protocols that you use. So the way around here in this case is I remove the implant, and I immediately, so this is immediate, so I placed the second immediate implant in the same surgery, a longer implant, and we did again an immediate provisionalization, and now with the longer BLX implant, it was perfectly supported. So even in that case, you can definitely have a workaround, and this is just one of these very few examples where we get early implant losses. So we could discuss the entire afternoon about how to deal with compromise, so non-intact sockets. And this is how we do it in most of the cases. So when I extract, when I get the impression the buccal bone is completely missing, I will definitely take advantage of an immediate protocol. So I place the implant immediately. I do the GBR, I do the reconstruction in the same surgery, and I go for a submerged healing, and I deliver a bonded bridge for the next 4 to 6 months. Because I know when I do not provide a proper volume at the day of extraction, I will likely end up in a severely compromised situation 4 to 6 months later. So this is the situation, the restoration, and the final crown. And I would say this is also one workaround how to deal with severely compromised extraction sockets. So let me give you some final data on clinical outcomes. And at the end, as Franz has nicely summarized, the expectation of the patient is always high. But we also have high expectations, and the first was, what about peri-implant diseases? So here with the BLX implant, we looked in a cross-sectional study with a functioning time of at least 1 year, so even longer periods, and we screened all these immediacy protocols for peri-implant diseases, and they are within the range of what we see for all other treatment protocols. So no peri-implantitis here in this cohort, and you see mucositis lesions at a very low level. So there is obviously not a risk factor for peri-implant diseases, and high pink aesthetic score values, as you can see here in the summary. So the only thing that we consider is, based on the comparison between type 1 and type 4 placement procedures, is that we get a more pronounced remodeling of the soft tissues. And this is clearly be seen here in the analysis. We end up in a slightly thinner mucosal biotype over time. And that might be prone to mucosal recessions. And that's why, specifically in patients with a very thin mucosal biotype, we provide connective tissue grafts. And this is one of the main recommendations in the literature to support the buccal mucosa immediately during the surgery by means of connective tissue graft. So in conclusion, and I think the indications became really apparent, so stick to intact sockets or damaged sockets up to 50%, 35 Newton centimeter or more for immediacy restorations. So this is important, having the proper implant design, progressively threaded implants without any discussion, and that's why BLX and TLX are our standard implants for this indication. So the risk factors are also apparent. A low primary stability should be approached by a submerged healing with a punch, as I've indicated. Thin biotypes, always go for connective tissue grafts to stabilize the mucosa. And when we have severely damaged sockets, we definitely place the implant, we graft, and we wait for another 4 to 6 months. So the good news is, it's all evident. We have the perfect scientific background, and on top, we know that we do not predispose implants to peri-implant diseases by using these protocols. So this one is our protocol, so how we do it. And of course, there are many other aspects that we could discuss, but I think this is, I would say, the main body for the discussion.
But this is absolutely fantastic, Frank. I think, thank you. Thank you so much for really bringing the evidence, a clear decision-making on how to select the proper patient and execution both of the surgery and the immediate loading procedure. So thank you very much, Frank. And now I would like to welcome actually our next speaker, Dr. Miha Pirc.
Thank you.
So Miha, welcome on stage.
Thank you.
So you are from Slovenia, where you studied dentistry and periodontology.
That's true.
And then you moved to Zurich, the University of Zurich, for a fellowship, and now you decided basically to stay in this team.
Well, yes, it's still undecided where we continue our life, but yes, it's been 6 years now.
So it's our great pleasure to have you on stage today to now focus, still of course in the topic of immediacy, but now going alongside a little bit on the peri-implants, tissue health, and you are going to focus on soft tissue management from different perspectives. So we are very much looking forward to your talk. So the stage is yours, Miha.
Thank you. So dear friends and colleagues, it's my pleasure to welcome you also here from my side at this amazing forum organized by Straumann to talk about the topic that is very, very close to my heart, which is peri-implant soft tissue stability and the potential influencing factors. As you can see in the background, we have an amazing venue. So a lot of history, a lot of tremendous buildings, musical parts, but there are also some things that you probably notice, and these are the white horses. They tend to be originally from Slovenia, my home country, and in order to train them well and everything, they're quite known to be a little bit stubborn. So it is somehow correlated also to the topic that I'm talking about today. If we don't train ourselves well and don't respect the nature, in our case biology, we will never be successful. And nature or biology will very fast show us who the real boss is. And I would like with that to show you the real stars of today's lecture, and these are these 4 patients. Everyone carries a very special story. However, they are the ones why we are here. We are not here for the sake of our treatments, but we are here and in our offices for them. So I will guide you with something to relate how the accidents or somehow how something happened with lower right-hand side sign. And I would like to start this part with Hans Rudi. So he is a special case for me personally because he was previously treated by one of my mentors, Daniel Thoma, and he came to me to our emergency clinic with a problem. So he went during the evening to the toilet and crashed into the door. So he came in the morning with a mobile central incisor. So when we took the radiograph, this is what we got. So first of all, what you can see, very beautiful, stable marginal bone levels and an old SLA active implant placed by Daniel Thoma approximately 13 years ago. And we see a horizontal fracture at the tooth that makes him problems. So of course, I don't want to be anything worse than my mentor. So we did a surgery together. I had the pleasure of that. And we decided that we have to also cover the recession at the central incisor next to it. And in order to come to the beautiful final result, at least from the soft tissue part, prosthetic could have been, of course, nicer. It's not a high aesthetic case. We have to respect certain points. And this will be the menu of today's lecture. So first, the biological part. Then second, as the main dish, will be the soft tissue part. And then last but not least, the dessert, the prosto part. So with this menu, we can start and continue with biology. You've already heard several times this saying, bone sets the tone. It does. And it is important, especially when we're talking about immediate implant placements, that we follow these rules. So this is Vincent on the case where we can show perfectly what happens when we have to extract the tooth and what happens with the soft and hard tissues. So he came to our clinic during Corona, a golden retriever, his dog jumped into his face. You can see that this tooth has seen a lot. And in this case, it fractured. So we had to extract it. Unfortunately, we couldn't place an immediate implant case in that, immediate implant at that case. So this was the extraction socket. You already seen the fistula, meaning we don't have a lot of buccal bone plate. And this was the healing after 7 days. So a week after, you can already see the horizontal and vertical collapse of the soft tissues, which don't have the support anymore. But I've already mentioned the thickness of the buccal bone plate. So if we look at the literature, what can we expect in general? These are the very mean values based on the sample of the patients between 17 and 66 years. So the average numbers that they report were between 0.5 and 0.7 millimeters, the thicknesses. Then there is another structure that we have to keep in mind, and this is the bundle bone. So sometimes we forget our first years of dentistry. However, this is a very important part, because bundle bone is heavily dependent on the tooth. So as soon as we extract the tooth, this bundle bone won't have the information from the periodontal ligament, and it won't have the blood supply, the nutrition, and the cells. And on average, the thickness of it is between 0.2 and 0.4 millimeters. So being the characteristics heavily tooth dependent, it is unavoidable we will lose this part. Either it will be replaced or we are going to completely lose it. So if we go a little bit further, what happens after we extract the teeth? We get some loss. And the volume loss on average can reach in the horizontal aspect after 6 to 7 months up to 63%. In vertical, up to 22%. So let's see what happened with Vince. So that was a week after, not very nice healing. You can see the contour, you can see the collapse of the soft tissues. And then 7 weeks later, this is what we got. So this is very much in line with the literature. So yes, in this case, bone will set the tone when we place the implants. And what about the soft tissues? You know how the saying goes, bone sets the tone and soft tissue is the issue. So why is it the issue? Sometimes because of our principles. We still believe that implants are almost the same as teeth. They're not, they're similar, they're very good replacement, but they will never be teeth. And there are some fundamental differences. One of them being the absence of periodontal ligament, so we have a direct bone contact. Without periodontal ligament, we also don't have the same vascular supply. The fiber orientation is different, and junctional epithelium around implants is more permeable. It has fewer fibroblasts and a greater number of collagen fibers. So if we look very schematically, what we expect around our restorations, there are 3 parts that we have to pay attention to. One is sulcular epithelium, the second part being the junctional epithelium, where we want to have at future some attachment, and the lower part, which would be the connective tissue. So with all these concepts, we also had to kind of like keep them in mind when we were treating Hans-Rudi. So we planned the surgery in advance, discussed with the patient that we are going to replace also the frontal crowns, as well as Frank also tried to be as minimal invasive in the sense of extraction as possible, so also used the system for vertical surgical extrusion, extracted the root. Here you can see that we were in deficit already from the beginning on in soft tissues. Placed the implant at the right prosthetical position, harvested the connective tissue graft in order to cover the recessions in a tunnel approach, and then double folded it in order to compensate for the soft tissue deficit that we had at the tooth 1-1. So you can see the occlusal picture, and then you can see now how it was when it was time to actually restore this implant. You can see the full coverage on the tooth 2-1, and around the implant 1-1, a nice emergence profile. So we had to go through some work in between in order to come to this final result. And of course, as Franz mentioned, it is very important that we instruct our patients how they should clean it, because we want them to maintain this. Otherwise, also our pictures won't look that nice. That's the least of the problem, but still. And then if we said, okay, bone sets the tone, but is soft tissue really the issue? Well, if we look in the literature, it is one of the main concerns when we are talking about aesthetic area and aesthetic complications. So it is the most prevalent aesthetic complication in the sense of asymmetry, asymmetric appearance, the mucosa level, and then the next one in line is the papilla presence. Only later come the open contacts and so on. So what is actually the cause for buccal soft tissue dehiscences in the aesthetic zone? Well, we can have a look in the literature and see in this publication from Mario Romandini when he was still at Complutense University, where they tried to evaluate the prevalence of buccal peri-implant soft tissue dehiscences and define the risk or protective factors. So they realized that there was a prevalence of these soft tissue deficiencies of around 17%. They still had some healthy and peri-implantitis cases, the healthy ones with a prevalence of 12%, and the peri-implantitis ones with the prevalence of 27%. If we go a little bit further and we see what were the disc risk or protective factors, the main risk factor was buccal positioning. And this was with an odds ratio of almost 15. When we see the second part is the thin phenotype, so odds ratio 8. If we dig a little bit more further in the literature, we see this beautiful publication from Auser-Masquite and Sader, where they also defined two main risk factors. One of them being, again, the bucco-oral position, and the second one being the soft tissue phenotype. So how do we define peri-implant phenotype? Well, there are 4 parameters that we have to assess. One is peri-implant bone thickness. Second one, keratinized mucosal width. Third one being the mucosal thickness, so horizontal aspect. And the fourth one being the verticality, so supracrestal tissue height. So all of these parameters have to be in line in order to have the right phenotype. So now I would like to introduce you a very, very special patient for me personally, because he is the father of my fiancée. So he had a problem with the tooth to 1. It's evident he was not happy with the aesthetics and everything. However, now he started to have there a problem and an infection. So he smiled and everything. He's a very happy person, but this was his clinical situation. So you can see, not an easy situation and not an easy patient, because you don't want to spend all of your Christmas evenings looking at your result if it's not optimal, and especially not having your future mother-in-law next to you judging you for it. So we decided that to still go for an immediate implant placement and then trying to load it immediately. But there is another factor here that we had to assess, and this was also the soft tissue thickness. So in a systematic review that we prepared for one of the consensus conferences from 2021, where we tried to assess what is the influence of thin as compared to thick peri-implant soft tissues on the aesthetic outcomes. So if you look at these forest plots, you can see the results here for papilla index, where you can see that all of them were in favor for thick tissues. Then the next one that you can see is the presence of papilla. Also, just the presence will be very much in favor of the thicker tissues. So based on this data and 34 included manuscripts, we concluded there was a significant increase of pink aesthetic scores and a higher chance of papilla presence. There were also less recessions over time and higher patient satisfaction in the group with thick soft tissues. So with that in mind, we also planned Damian, so my girlfriend's father, virtually extracted in co-diagnostic the root of the tooth in order to simulate, to kind of like visualize what we actually have there. Planned the implant, in this case a Straumann BLX implant, in order to gain enough primer stability to also immediately load the implant, placed it away from the nerve and in the right prosthetically guided position. And this was the time point of the surgery. So extraction of the tooth, you can see that it's also not very favorable because it's heavily buccally positioned. You can see now, after the extraction, the immediate collapse of the soft tissues where there is no bony envelope. Implant placed in the right prosthetic position, so deep enough in order to provide us with enough space for the soft tissue support. And harvested the connective tissue graft because we also wanted to coronally advance the flap in order to balance the irregularities. So now, at this point, comes the prosto part. So if we said bone sets the tone, tissue is the issue, then definitely pros is the boss. I know it's a perio congress, but still, in the end, pros comes at the end. And if we don't do the right steps for prosthetic work, it will not work. So that's why it was also important to plan all the parts of the restoration already at the time point of the implant placement, because we want to choose the height of our titanium base, in this case, that is in favor of our future restoration. So then we have to ask ourselves, if we come back to Hans Rudi, what was actually the steps that we had to achieve in order to come to the emergence profile that we had, and why is it even relevant? So if we look at this picture, you can see 3 different colors here, and 3 different zones, or 2, depending on the publication. One of them being the first one from Sue, they divided it in 2 sections. So one being the subcritical and critical contour. So critical contour, the one that is at the coronal aspect, the last millimeter that goes circumferentially, and the lower part, which is the subcritical contour, where we want to have the convex profile. If we look then at the other publications, we can also see that there is divided in 3, the aesthetic zone, the bounded zone, and then the last, the crestal zone. So if we link that to our scheme from the beginning, you can see also in which parts we want to be with our restoration. So we want to have the E zone at the top, so at the margin of our restoration, the junctional epithelial side with the heavily polished 0.2 micrometer at least restoration there, and the connective tissue part, which will be where our titanium base will be. So with that, we can also see on the example of Seval, who is also a patient that came after trauma, and unfortunately, we were not allowed to place an immediate implant here, which is a perfect textbook example for an immediate implant. So we again went for the vertical extrusion, surgical extrusion, and we wanted to prevent any loss of soft tissues. So decided to go for the extraction, ridge preservation with a rotational palatal connective tissue graft, tunnel the palatal aspect in order to really not cut through the papillas at any certain point. And this was then the healing and the suturing. So then when we finally come to the prosthetic part, this is what we start with. So in order to come from this to the right emergence profile, there are several steps. And this is how our provisional looks like, so where we already define the margin of our future restoration and the C zone, so the crestal zone with the prosthetic work. So in order to come from this to this, takes several steps. And then the only job we have to do is to scan this provisional and provide our technician with the right information so they can replicate it. And we can then take nice pictures of the surgical papillas and the final result. When we look from the side, it's a beautiful integration of soft tissues also around the prosthetic work. And if we really look at her smile, you will see why we really were careful, because this is her real smile. So here, if anything would go wrong, it really would not be a nice result. So when we get something like that from a technician, we want to change it to this. Why? Well, the reason is that there are publications also on soft tissues and especially on the provisionals from our department, where you can see that they try to test whether the emergence profile, being the convex or concave of implant-supported crowns, influences the mucosal margin stability over the period of 12 months. So they concluded that the use of implant-supported provisionals with a concave emergence profile resulted in a greater stability up to 12 months. So I'm lucky to work with friends. They're not just my colleagues. So with friends, Francis Strauss, Leonardo Mancini, and Lorenzo Fiscalini, we made 3 different designs, also, or 2 different designs of the individualized healing caps. We have one with the concave profile and one with the convex, and then tried it on the ultrasound, how the perfusion actually looks like. And if you have a look here at the videos, you will see that they differ. The third one is just the regular healing abutment, and then the 2 different designs. So if we look at the screenshot, you can see where the convexity is, the blood inflow was still coming in. Where the convexity was, there was none. So the concave actually gives the tissues the space in order to come in and ingrowth. So it's the same as we are on the tram. If someone stands next to us, we're going to move away. We don't want to be there. So we have to leave the space for the tissues to grow in. The same, that's what we did then with Damian. You can see that we coronally advanced and left the space. I intentionally didn't close here the papilla and left the provisional with a lot of space because of the swelling, and we know that it's going to slowly adjust there. So tried to also match the amalgam fillings with the chimney. I covered it then, but just for the sake of the picture. And I was lucky enough that we could take the CBCT after the treatment, so you can see how much space we left for the soft tissues to ingrow and the bone to surround the implant. So luckily, they were flying over Zurich 5 days later, because they also live in Slovenia, so I could take at home the picture of the healing, which goes very much in the favor of what we wanted. So it filled slowly the gaps and provided us with the result that hopefully I'll have peaceful Christmas dinners in the next years. So with that, we can slowly a little bit conclude and summarize based on Jennifer. So she is a daughter of a dentist, 60-year-old patient that you can see perfect oral hygiene, took care of her teeth the whole life, and came because she realized that something is off on the left canine. When we took the radiograph, this is what we have. So we can all agree it's not a maintainable tooth, so had to extract it. We were not able to place an immediate implant in this case. However, we went step by step. So this is when we removed the crown. You can see that there is still some root inside, had to extract that, had no buccal bone plate, did a ridge preservation in this case. And then we come to the implant placement. So here we have to stay in focus, plan it well, so that the prosthetic, the restorative position is obtained. So here we can say, okay, this was good. Then comes the soft tissue part. So we need the thickness of the soft tissues, the height and the thickness. So in this case, we had to augment them slowly, and also can say soft tissue thickness was well done. Then comes the restorative part. So we have to surround ourselves with the technicians that are great in order to have these nice results and that understand also the biology. Otherwise, we have to teach them about biology. So we can say also here, prosthetic design deserves a check. So take-home messages of my lecture today, based on the starting point, are those. So soft tissues, I hope you can all remember the thickness matters, being either horizontally or vertically, and keratinization, which we didn't address because usually it's not something we have issues in the aesthetic zone. Prosthetic design matters. And this is the emergence profile and the material. And the implant position, it has to be in the right 3D position. Otherwise, we have to keep in mind that even if we do everything right, in the end, according to this publication, the average annual maintenance cost can amount to even up to 9% of the initial cost over the period of 10 years. So in the end, it's all about planning. And you've heard this several times, failing to plan is planning to fail. But also, I would like to add that biology is king, but the selection of cases for immediate or not immediate is queen. And we know who rules the world. With that, I would like to thank you all for your attention, also on behalf of the best team ever from Zurich, and thank you for your attention. Thank you.
Thank you so much. Thank you so much, Miha, for really bringing all this together, all the different aspects, you know, from planning, surgery, prosthodontics, in order to reach one common goal, is to enhance the peri-implant soft tissues.
Wonderful. Thank you very much.
Thank you.
Thank you.
So now I would like to move to our next speaker. Our next speaker, this is Dr. Jasper Thoolen from the Netherlands. You are trained as a prosthodontist, but in your daily practice, private practice, you are doing like pluridisciplinary. Basically, you go from surgery, but also orthodontics.
Yeah,
and
correct.
you want, in the next 25 minutes, to really demonstrate us how ortho can really implement the overall restorative treatment. So I hope you're going to rock the stage.
I hope so.
What you don't know is that Jasper is actually a semi-professional hard rock guitar player, so I'm sure you're going to rock it.
Thank you so much. Thank you so much for the introduction, Frans. And I mean, it's quite a big honor for me to be on stage with people like you guys. It's absolutely amazing. So let's see if we can pop up the presentation. I don't see it yet. Yeah, there you go. All right, so my topic of today is multidisciplinary approach in immediacy, but focus on orthodontics. So, I'm Jasper. I graduated 8 years ago from dental college in Nijmegen, and I'm a prosthodontist. So probably you guys are figuring out, what am I doing here, right? I mean, it's a meeting about implantology, about periodontics, and what does a pros have to do here? So I'm not an implantologist, yet I do place implants a little bit. And I'm also not an orthodontist, but yet we still do a little bit of ortho. So again, what am I doing here on stage? So the next 25 minutes, I want to take you all in my little journey that I call everyday dentistry. So I have my own referral practice in the south of Holland, where we do approximately 90% of referral dentistry. So most of the time that we see a case in the clinic, we approach it like a team, right? Because it's almost never only ortho. And that's the thing. Quite a lot of times people are referring patients to our clinic and they say, please place an implant, right? Please do ortho. But quite a lot of times, it's not only that, right? We see a case, a human being, a patient as a whole. So we try to have a really good holistic perspective on how to formulate and actually treat a patient. And a good starting point for us is always digital smile design. So as a prosthodontist, I was also educated as a DSD master. And there's a big association and misconception in digital dentistry and digital smile design, because usually this is our typical DSD case, right? There's a beautiful lady coming in, she doesn't like her smile, so we are making some pictures, we're going to analyze, and based on the face, we are going to calculate the overall design of where we want to go to. So it's like a backwards planning, and the only thing we had to do here is we had to work additive. So we based on the face, we have some guidelines, and we start to design digitally. We tried it in the mouth, so we used like a mock-up, and then we are going to take a look. So it's the thing that we are actually designing digitally, actually working out for this patient, because we can try and design everything digital, but still patients are very analog, right? So we have to try to see if this will actually work out. So this is the try-in. We didn't touch her at all. We just put in our design in the face, and we are going to see if this is what we want to make, if this is actually be suitable. And then we use this design to prep through the design. So we have all these little bursts that we can use to try to prep as minimally invasive as possible. And minimally invasive dentistry is important because for some reason, sometimes as dentists, we think that we can do it better than Mother Nature, which is, in my opinion, a very arrogant way of thinking about dentistry. And then these are the final preparations. We're going to place the veneers on a rubber dam, yada, yada, yada. We have like a nice smile. She's very happy. We are happy as well. And we came a long way. We have some nice aesthetics, right? So this is usually DSD as we know it. But to be fairly honest, I don't really care about all that stuff. I do care about the design part, because the nice thing about digital dentistry nowadays is that we can work more minimally invasive. And this is a different case. We were doing a full restorative, like a full rehab case. And what you see here is I took off the old crowns. And what is nice to see is that in dentistry, we have come a long way. This is good news for dentistry, right? And I'm not showing this picture because I want to show that I can prep super minimally invasive. No, I want to show this picture because sometimes we also forget that in teeth there's a pulp, and sometimes we just forget it, right? And there's this research done by Daniel Edelhoff, which I think is super important, because this article is showing us the amount of tissue that we as prosthodontists grind away when we are making actual restorations on natural teeth. And even in my super minimally invasive preparations, that's still 16 to 17%. And on a full crown preparation, that is still between 60 and 70%. And in my perspective, that is quite a lot. If I would have been a pulp, I would get really angry if 60% of my body would have been cut away, right? So we try to be as minimally invasive as possible in prosto, which means that sometimes this is the only preparation that we have to do. Because it's the only space that now in modern day dentistry we need to actually fabricate our ceramics. And we can use digital design to see if this will actually work out. And there's a very famous German painter, Hans Hofmann. And he's saying design is the intermediary between information and understanding. So now let that sink in a little bit. It means that we need design to understand what we are doing and where we want to go to. And I think that is important because when we have like almost the same case, because also this lady is missing her lateral incisors, right? And now we do this DSD, and now we are going to start ask ourselves, and this is basically what my job as a prosthodontist or as a restorative dentist is, to ask these questions every case, every day of the week. So the first question is always, are the jaws in the right position? Second question, are the teeth in the right position? The fourth question, do we need to place implants? Do we miss teeth? Then the fourth question, what about centric relation? What about the vertical dimension? And then we go to perio, and then all the way to the end we go to restorative only, right? To work only additive. And I know that on this meeting we are focusing on periodontal and implantology, right? But there is a question that always needs to be asked before we even go to that point, which is ortho. And literature is showing us, it's a brilliant article from Brunel, that in restorative dentistry, almost 45% of the patients would have actual restorative advantage by doing ortho first. And only 1% of these patients gets actually treated. And there's a big gap, right? And I think it's important to acknowledge this because quite a lot of times we just accept the situation that we see and we try to place an implant, we try to do perio. But I think to really understand and try to acknowledge that sometimes we have to improve our starting position first is a very valid question, right? And Christian Koosman says this beautifully, he says every restorative case is an ortho case until proven innocent. And I really love that quote. So this is after a little touch of ortho. We just did a little ortho for 3 months. And now we made space on the premolars because we know in this case these premolars should be canines, right? So then we just make a few veneers. This is the end result. And it is important. Why? Because this is her final smile, right? We see the gingival architecture being well established. But Dr. David Garber told us that the white is determined by the pink. So this is one of the reasons why me as a prosthodontist, why I'm on the stage telling you about, okay, we need to take the gingival architecture, the pink architecture, always in consideration. Because as prosthodontists, we always think about ceramics. We always think about composites. And we tend to forget the gingival architecture. And I think it's super important. Right? So this is the final smile, the final results. So the backwards planning is really helping us out. Right? And we can use it not only with normal orthodontics, with brackets, now we can use it with aligners as well. So now this is my starting position. And the actual treatment plan that we make here is based on our starting position. So what we see now, we see 3 a little bit bigger diastemas, right? So the first thing we do, we start to make pictures, we start to digitalize the patient, and we start to do an aligner planning. And we did this with ClearCorrect. So we start to plan, and I know that I have 3 bigger diastemas, but I also know that I want to make ceramics. So why not use the space that Mother Nature already gave me to make room for my ceramics? Why? Because I don't have to grind away any tooth material. Because we want to be as minimally invasive as possible. So this was my actual planning. So we divided the bigger spaces in 5 little ones. Because I know that this will be my eventual ceramics. And this is after wearing 10 weeks of aligners, which is not even 3 months. There has never been a patient in the practice that told us, no, I think that will be too long. And it's interesting because with a little touch of ortho, it gives you such a powerful tool to have a better starting position. Because now this is my DSD. And now the only thing I have to do is to place a few veneers, right? And then this is the end result. And we have a good, stable, functional relationship. And we try always with an Essex retainer, we start to stabilize the actual situation. And we came from here to here. Again, this is just a little touch of ortho that we can use. And I'm showing you this because this is the easy part, right? But all the easy things are, this is quite easy as well, actually. It doesn't look that way, right? Because if this is the starting point of your treatment, where do you start? Well, this is what we think about interdisciplinary communication. Everybody's sitting on the table, high-fiving each other, and everybody knows what to do, right? But the honest truth, that this is the way that we communicated in dentistry for quite a long time. We used pieces of paper, we used like the old school models, we used an articulator, a little piece of paper where we written down, I just want a crown, 3/6, color A2. We send it to the technician, and the technician should do something magically with it, right? But this is the way we were communicating for a long time. But now we are doing something different, because we are actually shifting dentistry from multidisciplinary to interdisciplinary, and those are two very different things. So this is multidisciplinary. So we have a case. Case has been sent to the ortho. And the ortho says, oh yeah, but we need to know a little bit where the prosto wants to go. So please go to the prosto. So then the patient goes to the prosto. And they say, yeah, but I mean, your jaws are not in the right position. So please go to the maxillofacial. Who sends you to the implantologist? Who sends you back to the ortho? Who sends you back to the maxillofacial? Then he sends back to the prosto. And eventually it will become one big mess of communication. Does this sound familiar? Because to me it does. And sometimes we forget that there's a patient involved, right? Sometimes we forget that dentistry is actually about helping patients. And our lack of communication is not really benefiting to the actual outcome of the treatment, right? So this is interdisciplinary. This is different. Interdisciplinary means that we are all sending and receiving. So we are collectively trying to solve these kind of cases. And that means that there's a vast array of different specialists included in solving these kind of cases. And we use SmileCloud for that, because SmileCloud for us is really beneficial in the communication of data between every specialist. And it's not only the specialists, but it's also like the laboratories that making the designs, which can be the implant planning, which can be the ortho planning, which can be the maxillofacial planning, which can be everything. Right? So not only do we use this for a DSD tool, which SmileCloud is quite known for, but I think this is the most important part. All data, the pictures, the scans, everything is on there. We can share it, right? The design lab, they can make a full 3D setup, and then we can get results like this. And the interesting thing is we could have never acknowledged, we can never have done this without having a good communication, and I think that's super important. So also like these kind of cases, this man comes in, where do we start? Well, the actually starting point is to create a reference design. The reference design, also as we call it the 3D smile design, we call it a master plan. And we try to solve the case all based on the master plan, right? Because then this is the master plan. You see it in the white. The white is our 3D DSD. And now we start to define our restorative strategy. So who will be involved in actually solving this case? Well, the first one, of course, is that question, are the jaws in the right position? Yes, they are. Are the teeth in the right position? Well, based on the master plan, yes, more or less they are. So do we need to place implants? Yes, we do. So we add the implant design center in this case. But we also need to raise the bite because we have a functional problem and we do have to do some restorative. So I just add my dental technician in this. And all together we start to collaborate and to discuss and communicate on where we actually want to go, right? So this is eventually what we did. So we just rebuilt with composite the master plan. We transferred it into the mouth of the patient with a formal injection technique. How precise is it? Well, white is the DSD, and the beige, the brown, is what we actually ended up with composite within 1.5 hours, right? And my starting position now is becoming way better. So how precise is this? Well, actually pretty precise, because now, as you can see, it's 0.6 mil of precise composite transferred from the master plan. And now my starting position for placing implants is becoming way easier, because now you still see on the white all the places where we do have to place the implants. And we use the design and the master plan to define where we actually want to place these implants. And the implant placement will be planned because we want to do this guided, right? So we start from something that's really complex to something that becomes really clear. And I think that's something that really helps me out as a prosthodontist. Because sometimes people saying, so we make something complex, we make it simple. But still, these procedures are sometimes very hard to execute. So it's not about simplifying, it's about clarity. And I think clarity is very important. Same goes for this patient. I mean, this patient comes in, we make pictures, we start to analyze, we see some problems. But again, we start to do our restorative strategy. First question is, are the jaws in the right position? Well, yes, they are. Are the teeth in the right position? So no, they're not. So I'm adding my orthodontist, Andrea Bazucchi, into this case. Second question, do we have to place implants? Yes, we do. So we just add the implant planning center. And then what about centric? What about perio? What about restorative? Well, we have to make something on those implants and eventually perhaps some restorative. So also let's add the laboratory, the design lab into this. But it's a complicated case, so I can also ask for somebody like Caroline Hochberger from Germany, just add her to the case digitally, and she can see all the data, she can see what we want to go to, and she can help me in consulting. Same goes with implantology, because it's quite a hard case to place implants, because probably we have to do it like directly in guided. So I'm adding my father, who is an experienced implantologist, into the case, and I'm adding my assistant, who will change the aligners for the patient, into the case, and everybody knows exactly what we're going to do. And I think this is the beauty about digital communication nowadays in dentistry. So what we do, then we make the ortho planning within the clear pilot system. So now you can actually see where we want to go from an ortho point of view, also from the occlusal point of view. And then we start the orthodontic treatment. And then the patient comes to the office and says, okay, there's something missing, right? And now we see this in the mouth. So during ortho treatment, we can even use all the design and communication that we already have from this patient to design where we want to place the implant. So we do implant planning. We want to do the 3/6 immediate. We use the iXtel system for this. So we make the guides, and now it becomes really easy for me as a kind of unexperienced implantologist to place implants. Right? So we extract the tooth. We use the guides, we place the implants, we close it off, and then this is how we eventually ended up, and this is what we planned. So I think this is super, super interesting, because this is really helping me out as a prosthodontist to help this patient, and eventually we go further with the aligner treatment, because then we just replace the aligners as our professionals, right? And it's interesting, because this is after 3.5 weeks after surgery. And now we just continue with the ortho case, and whenever the ortho is ready, we can proceed to the prosthodontic phase immediately, because we know that the implant will already be grown in the bone. But this is the amount of data that we use nowadays to define strategies and treatment plans. And can you imagine that for an unexperienced dentist such as I am, this really helps? Because we can see so much, also from an ortho perspective. I mean, the biggest problem with aligner therapy is that we only scan the upper part. We only know the coronal part of the teeth, right? But with this kind of data, we actually see the form of the root. So the plan that we are making with the aligners will be better with this kind of data than without. And we all know that the outcome from an aligner treatment is just as good as the plan as you make. So the planning part is super important. And it's all about communication, because you can imagine if this kind of data is accessible to everybody who will be working on this case, it will be really valuable, right? So this is how we approach dentistry. We try to approach dentistry from a holistic point of view. And this is the reason why I think it's important to connect the implantology and the periodontology, but all kinds of dentistry within this kind of case design and treatments. And as the Beatles once said it beautifully, with a little help of my friends, I mean, I'm a super mediocre dentist, but I'm pretty good in surrounding myself with people who can do a far better job than I can. Right? And for me, that's one of the key takeaways from why we use SmileCloud or other digital platforms to design our treatment plans. Because eventually digital dentistry will absolutely lead to a better team communication, a better treatment execution and outcome predictability, but it mostly and foremostly will give you a lot of joy in your dentistry, and that's what I really love. And make no mistake, this is not like future dentistry, this is how we operate every day of the week, and I think that's super important. And as the team from Florin is now designing 3DNA, we will even take it a bit further, right? So the design, the way we can actually plan our dentistry nowadays is taking a big leap. And also make no mistake, if you think that you are too old to go into digital dentistry, and we hear this quite a lot, we hear the older dentists saying, this is nothing for me. I mean, these are, as we call them, Waldorf and Stadler, like the Muppets in our clinic. This is my father, who was 65 years old, and Eric, who was 72 years old. These guys have been able to create fully digital avatars, put it on SmileCloud, create full digital teams, and send it away to everybody they need to actually execute the treatment, right? If they can do this, I'm pretty sure everybody in the room can do this. And with that, I want to thank you guys for your attention.
And now you play guitar?
Want to play guitar?
No, just kidding. But thank you so much, Jasper, for really highlighting how orthodontics can really help in the overall treatment, how nowadays in the digital time, how basically we can communicate, collaborate, and basically provide better treatment to our patient. I think it was an amazing session. We were lucky to have these great speaker, talented scientist, clinician with us. And with this, I would like to wish you all an excellent journey in this wonderful Europerio. See you soon.